Hello and welcome to the 2020 Brain and Transcranial Photobiomodulation Virtual Summit. I'm Dr. Joe Didero, your host. My guest is Dr. Marco Antonio Caldieraro. He is an MD, PhD psychiatrist, currently working as an assistant professor at the graduate program in psychiatry at the Universidade Federal de Rio Grande do Sul in Brazil. He's an instructor for medical students in psychiatry at the Hospital de Clínicas de Porto Alegre, also in Brazil, and he's teaching at the hospital there. Both of these institutions are located in the city of Porto Alegre, Brazil. His research focused on mood disorders, and he got his master's science degree and his PhD both there. And in 2017, he was awarded the Young. What was that thing that you would get? The New Investigator thing?
New Investigator Award from the ASCNP.
And what does that mean?
It's American Society for Clinical Neuropsychopharmacology.
Wow. Now you did your. Thank you for coming on. Thank you for your work there and participating. Now you were from 2016 until September 2017, you were a research fellow at the Dalton Family Center for Bipolar Innovation at Massachusetts General Hospital, Harvard Medical School. Tell us about that. Tell us, what is that? How does that set up? What does that do?
It's a clinical and research program in bipolar disorder. It's led by Dr. Andrew Nierenberg. And I went there for this fellowship, and Dr. Paulo Cassano was collaborating with Dr. Nierenberg in a photobiomodulation study. And that's how I got into photobiomodulation. I knew about it for psychiatry and started collaboration and research on this.
You started to pay attention to that stuff. And what was your first impression when someone told you, you put light in the head and people get better? What did you think?
Not possible.
People must be mad, right? You're dealing with a little bit of madness anyway, right? So,
yeah.
So that's what really we find for most of them. And then they have the inquisitive, curious minds that want to go forward and, figure out how does this happen? What is the deal here, right? That's kind of how it goes. And you're in there in the heart of it, the seat of it, the Harvard and everything like that. They don't play around, right? This is serious science, right?
Yes.
And so what was your approach? What was your story? What was the first thing that you kind of looked at? How did it go?
Well, so I first started looking to some data from Paulo Cassano and doing secondary analysis and so on. And then most of the data I have here is from a systematic review I've done on data from both animal and human studies and photobiomodulation for major depressive disorder. Then I came back to Brazil, and I'm collaborating with folks here on an animal model study, and I'm preparing, actually I've already submitted a grant for a clinical trial on treatment-resistant depression.
Treatment-resistant depression. Now, this is a, worldwide phenomenon. And, we talked about depression, mental health, to the level of, young people are now suffering, from depression. Used to think it was like a middle-aged thing. But now millennials and more people, you're going to talk about that, the statistics of how this is, how many people are affected and afflicted and everything like that. You're going to talk about that?
Briefly, yeah.
Yeah. And then I'll fire off a couple questions, hopefully, to make it interesting. So let's go here. Okay. So this is a transcranial photobiomodulation for major depressive disorders, correct?
Correct. Okay, so my name is Marco Antonio Caldieraro. Thank you, Joey, for inviting me for this very interesting summit. I have no conflict of interest in this presentation. I'm a psychiatrist, MD, PhD from Porto Alegre, Brazil. Porto Alegre is a city in the south of Brazil, and it's a very nice city. You should visit if you can. This is the institutions where I studied and where I work. This is the School of Medicine of Universidade Federal do Rio Grande do Sul, and this is Hospital de Clínicas de Porto Alegre, which comes to be the school hospital of the Universidade Federal do Rio Grande do Sul, and this is the hospital where I work now. After I finished my PhD and at Universidade Federal do Rio Grande do Sul, I went for 1 year for Boston at Mass General Hospital at Harvard Medical School, where I spent this year as a research fellow working with this very nice team led by Dr. Andrew Nierenberg. At that time, they were collaborating with Dr. Paulo Cassano in a study on photobiomodulation for bipolar depression. And that's when I knew about photobiomodulation. I was skeptical at the beginning, and with time, I was getting more and more interested. At that time, I had the great opportunity to write chapters on photobiomodulation, both for depression and anxiety, and it was a great opportunity to study, learn, and to talk about clinicians where we know about photobiomodulation. So I work mostly with mood disorders, particularly with mood depression, major depressive disorder. Part of time I work as a clinician treating major depression, and part of time as a researcher. And my previous work, mostly before I start working photobiomodulation, was a lot on the heterogeneity of major depressive disorder, both in terms of clinical and biological aspects. And this heterogeneity has something to do with treatment-resistant depression. This is a very famous graph from a very famous study on major depression. And what I would like to emphasize here is that this is the remission rate of depression after 4 different treatments with adequate dose for an adequate time, and around 2/3 of the patients remitted with the treatment after 4 different treatment trials, and 1/3 of the patients still not responding even if we try different medication for them, and they are classified as treatment-resistant depression. And many clinicians believe that this treatment resistance is in part caused by heterogeneity of major depression. Imagine like this is a group of patients and all of them have major depressive disorder. And you have treatments that can address the ones in blue and green, but medication does not address the specific kind of depression that the people in gray have. So we can try different medication, but those won't get better because they have a different kind of disorder, maybe a different biology or so. And that's very, very common in depression, that is clinicians see very different patients that if you apply the DSM criteria for depression, they are classified as having major depression, but they are very different. And how much different they can be. This is a very interesting paper. It's just a discussion paper and mathematical exercise that this author, Dr. Oostergaard, made. He just took the DSM criteria for major depression and calculated the different combinations that could fit the criteria for a major depressive episode. And that's the number he got. Almost 1,500 different ways to get the diagnosis of major depressive disorder, just making different combinations of the criteria, right? And then the biological aspects, it's not that different. We have different theories and a lot of research, consistent research showing that different mechanisms are associated with depression. You have the stress and cortisol mechanisms, the monoamines hypothesis, you have inflammation, you have the neurotrophic hypothesis with BDNF and decreased synapses. And most recently have the glutamate hypothesis associated with the response to ketamine. Of course, many of those mechanisms have some links, and one thing affects the other, but probably have some patients with a very glutamatergic depression and others with a more inflammatory depressions. And we don't have how to separate them clinically. And that's maybe why we have these treatment-resistant patients, because some of those mechanisms are not being addressed by current treatments. So I have some of my research, and me and my group have some published papers on this clinical and biological differences between different kinds of patients. But there is one mechanism that we have some evidence that is associated with depression, but we don't have treatments that directly address this mechanism, and it's mitochondrial dysfunction. There's plenty of papers on it. And that's interesting about photobiomodulation, because its primary mechanism of action is the mitochondria, but it has secondary effects. After we activate mitochondria, we have the secondary effects on synapses, increased neurotrophins, increased neurogenesis, decreased inflammation, and all those mechanisms can help to treat depressive patients. But as I told you, I spend a significant part of my time treating patients, so all that theory, it's very interesting, but what made me into depression was just this graph here. It's the first time I saw this graph, I started to get interested in photobiomodulation. It's the results from the Related 2 trial from Paulo Cassano, where they could see a significant effect of photobiomodulation in just a small sample. In 2 weeks, patients were better than the sham-treated patients, and the effect was growing and even larger at 8 weeks. I was in Boston when I saw this graph, and then I had the chance to work with secondary data of this trial, and we published this paper when we could analyze in more details the side effects of photobiomodulation. This is the summary of this study. We saw that much more patients in the active treatment have side effects. It was just a trend for signification, but maybe because the sample is not that big. But non-patient reported any serial side effect. So my most important reading of this results is that, well, it's in general well tolerated, no serial side effects, but it has some side effects, which means that there's something happening, because sometimes we don't know if the lights really reach in the brain and doing something. So, Another paper I did on that time, it's a single case report for a patient who was on photobiomodulation treatment for almost 3 years. So it's only one patient, but it's very interesting. She used it to have severe depression, it's suicide risk. After she started the photobiomodulation treatment, she had no more severe depression, and the anxious symptoms, and this line you can see, were progressively decreasing, and the depressive symptoms stay under control. So after this small studies I participated, the secondary analysis in this case report, I got interested in photobiomodulation, decided, well, I want to know more about that and link it to my expertise in mood disorders. So we decided to do this systematic review on transcranial photobiomodulation for depression. And this is probably the first paper on photobiomodulation in a psychiatric journal. Most of the papers are on the laser medicine journals. So we got very happy when this paper got published on Journal of Affective Disorders. And what we learn on this review. So first, from the preclinical findings, the animal studies, we learned a lot of things very interesting for depression. First, this is one question this study tried to answer. So we need, one session is enough. We treat the patient one time and wait the effect, or do you need to apply multiple sessions, to deliver multiple sessions of treatment? And what does the study show, compare the same simulation in one session or repeating it 10 times and at different days, of course, and tested it in the forced swim test. It's a very common test for antidepressant effects of any kind of treatment. It's more validated for medication, but it's used for other treatments as well.
So just let me understand. If they force the rat to swim, and if he's depressed, he quits swimming early.
Yep.
And
He's more time in immobility, less time trying to swim.
I got you. And this one was done with a rat or a mouse that had no depression.
Yeah.
Go ahead.
It's a very standard protocol when you're starting to test an antidepressant effect of a drug, for example.
And what did you find?
And that's what they found. The significant differences, or the effect that they were able to demonstrate on the forced swim test was only when with the chronic treatment, which means after 10 sessions of photobiomodulation, and no significant effect after just one. So indicating we need multiple sessions of treatment. This is another study where they compared continuous wave versus pulsed wave. So they have a model of depression after traumatic brain injury on the mice. And they tested all with the same parameters, same wavelength, same total energy per session. And the difference was one group received dust light in a continuous wave, and the other two groups with pulsed wave at 10 hertz and 100 hertz. And what they found, this is the mean score in the neurological severity score after the TBI. So that's not depression, that's the other symptoms of the TBI, traumatic brain injury. And the 10 hertz was more effective than continuous wave and 100 hertz. And they also tested the forced swim test. And again, the result was more significant with the 10 pulsed hertz than continuous wave or 100 hertz.
This is looking at, go back there, because that was showing this is a different graph because it's showing how long they were immobile, how long that they didn't move. And the one with the 10 hertz moved more, right?
Right. Yeah, this is showing immobility period. So as more depressed, more immobile the mice or the rats stay. This is a different test. It's tail suspension test, where they suspend the mice by the tail, and very similarly they assess the immobility period. They stay when they are suspended. Similar results. Actually here, the 10 hertz also was different from the control, but 10 hertz were more significant. And this is a very important study because most of studies after that were influenced by these results, and the 10 hertz frequency become a tendency in later studies on depression, right? This was an influential study. Another thing that we learned from the studies on animals is that the treatment with transcranial photobiomodulation may be equivalent to some well-validated and very efficient drugs for treating depression. This is a study comparing transcranial photobiomodulation with fluoxetine. Here they use the model to induced depression in the rats, it's the chronic unpredictable mild stress model. It's a very well validated animal model for depression. They used multiple sessions here, 9 sessions, 3 sessions, 3 times a week. And then the forced swim test, the mean count of swimming were higher in this is light treatment compared to the drug fluoxetine, and both were better than stress with no treatment. And here is the immobility in the same test that should be lower if you're observing an antidepressant effect. And again, drug and light treatment were equivalent and better than no treatment. This is a different study with another very largely used antidepressant. And here they use the same stress model to induce depression, and then compared red light, 630 nanometers, and versus near 810 nanometers laser. They used 10 hertz pulse wave, again, multiple sessions during 3 weeks. And in the forced swim test, what they observed was that the near laser was similar to citalopram, both in immobility, decreasing the immobility and increasing the swimming, and that the near laser were better than the red laser in this study. In the same study, they tested for some biomarkers, so cortisol that was increased by stress compared with controls were decreased by citalopram, and red laser. In this case, the near laser was not effective in decreasing cortisol. And they also tested glucose level on the rats, which increases after stress and decreased with the 3 treatments: citalopram, red laser, and near laser. We also learned that dosage must be optimized, and there are studies from other fields showing that we have a sinus curve dose on photobiomodulation. We observed that this study reported this for depression. So what they did first was to compare, again, same wavelength, continuous wave, and they compared different powers of lasers. And what they found was that the 80 milliwatts laser was most effective in the forced swim test when compared to 200 and 400 milliwatts. Again, in all those parameters of forced swim test. After that, they tested, they induced depression with a drug called reserpine, and tested then only the 80 milliwatts laser that was most effective in the initial tests. And again, they repeated this result, showing improvement in forced swim test, but they also test an electrocartiogram in the rats. And they reported that the 7-day treatment, I mean, 1 session every day for 7 days, were also able to improve some electrocardiographical parameters that were disrupted by the reserpine and the induced depression. They observed this in delta frequency and beta 1 and beta 2 frequency. And the last animal study I'd like to show is this one. Again, forced swim test, tail suspension test, which are very standard for depression animal studies. So they induced depression and observed in this behavioral tests an effect. The mice received the treatment for 80 days, everyday sessions. And again, the difference were significant after 14 days. reinforcing that we need multiple sessions. And it was most significant at 21 days in one of the tests, and only after the 4 weeks of stimulation in the second test. Again, reinforcing the relevance of multiple sessions and chronic treatment. But the most important part of this study is that they really tested for mitochondrial biomarkers on the rats. So they could show that ATP was increased in prefrontal cortex for the treated rats. And for those who are not used, this is a part of the brain that is believed to be very, very important for depression. They also measured the cytochrome C oxidase level, and it was up. This is the expression of the protein in the tissue. It was increased also in prefrontal cortex, and they also assessed the CCO activity in the tissue, also increased after treatment with laser photobiomodulation. So we have this very interesting results from animal studies that indicate photobiomodulation may have a role in the treatment of major depression. And we also have those, but we were most interested in clinical studies, right? And what can we learn from them? So the first conclusion of this review is that we need more studies on depression, right? Yeah, we have one case report study, 2 open trials, 2 small clinical trials, and we have 4 open studies with depressive symptoms in patients with traumatic brain injury. They are not studies on depression specifically. Depressive symptoms are a secondary outcome. This is on transcranial photobiomodulation, and later I will show a few results on systemic photobiomodulation. So this case report is the one I showed you before. I'm not going to the details again. This open trial is a trial with a single treatment session at the forehead, aiming the prefrontal dorsolateral cortex. They used a LED device, 810 nanometers. And the physiological outcomes, what they found was that during the light treatment, the region of the brain that was receiving the light showed an increase in oxygenation. And they also have clinical results. Here is the Hamilton Depression Scale. It's a very standard scale for assessing depressive symptoms. This is before treatment. Then the patients received one treatment session and were reassessed 2 and 4 weeks later. So what they found was a decrease in depressive symptoms after 2 weeks, and a tendency that the symptoms start to increase again after 4 weeks.
The dotted line would be the mean, right?
Yeah.
You can see it that way.
That's right. Yeah. And they also assessed anxious symptoms, and the results are very similar, right? So meaning that they found an effect with a single session, but this effect, with time, that they started to lose this effect, reinforcing the need for multiple treatments, right? The second open study is a study called Elated 1. They tested 4 patients. It's a proof of concept study. They tested 4 patients. Stimulation was again in the forehead at 4 different sites. And here patients received multiple sessions of treatments, not only one. They received the treatment during 3 weeks, 2 times a week, so 6 sessions of treatment. And this is the result. So the arrows are the treatment sessions. So we see the patient started to improve during treatment, and this improvement continues after the last treatment section. And this results because of this promising results, the same group did the second study that's now a randomized clinical trial called Related 2 with 21 patients that were randomized to receive bilateral photobiomodulation aiming to stimulate the dorsolateral prefrontal cortex bilateral. It was 8 weeks instead of 6. Again, 2 sessions a week. And that's the graph I showed you before that put me into photobiomodulation. This is the results for the overall sample, showing a significant reduction.
Marco,
Yep.
So somebody who may not be, this is the Hamilton Depression Scale, and
yep.
What I want to say is, what is it? So a person that has a 20 is pretty depressed, right?
Yes.
So, but if someone goes down to like a 12 or a 10, how much is it something that you as a doctor would know? What's the minimal clinical important difference? I mean, for this type of a graph.
Yeah, I see. 20 is in the moderate to severe range. Remission is 7 or less, so 10 is close to remission. And many of the drugs used in clinical trials show 3 to 4 points difference. So it's a very big difference.
All right. So when you look at something like this, being a psychiatrist and everything, you can be, wow, this is a big change, right? But
yes,
for somebody like, Joe the plumber, it looks like a red line. That's all I wanted to. I wanted to pull it off. So this is almost to remission after 8 treatments, right?
No, 8 weeks, 16 treatments.
16 treatments. Thank you.
Yes. And this is the same result just for the completers of the sample.
That's good.
And this is the second clinical trial on photobiomodulation for major depressive disorder. And actually, it's not exactly a trial for major depressive disorder. It's also a trial where they tested attention bias modification, which is a psychotherapy that they were testing for major depressive disorder. And the idea here was to try if photobiomodulation could enhance attention bias modification. So it's an add-on treatment trial.
Nice.
Yeah. So all patients received attention bias modification therapy, and they were randomized to receive right transcranial photobiomodulation, right meaning right forehead, or in the left forehead, or sham treatment. They received only 2 sessions with a 48 hours interval. And then they assessed the antidepressant effect of the therapy in the 3 arms. And what they found was that for the patients who had a change in the bias for negative effects promoted by the psychotherapy, the stimulation with the laser in the right forehead enhanced this effect, but not in the left forehead.
Oh.
Yeah.
Infrared to the right side had a positive assistive activity with the therapeutic training that they were doing.
Yes, exactly.
And they didn't see that. They didn't see that on the left side.
Yeah, patients treated in the left side didn't show this effect. Again, it's a relatively small trial, but the results are very interesting, right? And then we have these 4 studies on traumatic brain injury, most of them by the same group. None of them is a randomized controlled trial. They were open studies or case series or one case report. And in general, what they see is that they report is that with repeated treatments in these patients who very frequently develop depressive symptoms, those patients with traumatic brain injury. So the treatment tends to improve depressive symptoms also with other symptoms these patients have. And interesting, we have some studies on what I call here systemic photobiomodulation. And by systemic, I mean treating depression with the light delivered to any part of the body that's not the head. I mean, other parts of the body. The idea here is that anti-inflammatory effects or other effects in blood cells can change systemically and reach the brain and have some therapeutic effects. The better studies are this in laser acupuncture. So it's tricky to understand these results thinking about photobiomodulation because they stimulate very specific points under the rationale of acupuncture. They use very low doses of light, like 3 to 5 joules per sessions. But they use laser with 810 nanometers or frequencies that we are using on photobiomodulation studies, delivered to different parts of the body to treat depression. Of course, if you are looking only like in acupuncture point of view, you would say, oh, that's because we are stimulating the exact points that are relevant for depression. Maybe if you're looking only with the photobiomodulation point of view, you could say, oh, it doesn't matter where are you stimulating, you're just giving light to some part of the body and it's having a systemic effect. But I mean, so it's a little bit tricky to read these results, but they found very nice results. So they have a protocol with 8 weeks of treatment, 2 sessions a week for 4 weeks, then 1 session a week for other 4 weeks. And what they reported was a consistent decrease in the BDI, which is a self-reported depressive symptoms scale. Much more significant in the active treatment than in the sham treatment. And a few years later, they published the second study, similar protocol, a little bit more energy delivered per section, but still 1 joule per point, 5 points, so 5 joules per session, very low energy. And they reported a decrease in depressive symptoms in 2 clinician-rated scales, but not in the patient-reported scale, which is kind of conflicting with the first results, but still in the clinician-rated scales, a strong and consistent result. And the same group also could show that the stimulation with laser in these points lead to modifications in brain activity. This is a study they did with fMRI during the time the patient was being under stimulation. We have also, it's 2 papers, but part of the same study published in Russia. It's an open study, and they have a control group that were similar patients from the same setting, but not randomized, just a control parallel group. Treatment-resistant depression, and they did it using a mix of transcutaneous, so light delivered through the skin, and intravenous photobiomodulation, I mean, like a optic fiber into the vein. And they treat the patients with 2 cycles of photobiomodulation. Each cycle is 10 to 12 daily sessions. And they reported a 36% of remission in the photobiomodulation group, compared with 14 remission in this control group they have. And then they followed these patients for 1 year. And those who received photobiomodulation during the acute episode, 23% had a recurrence of their depression in 1 year, and 50% recurred in the control group. Again, not randomized, but still interesting. And this is the last study I will show. It's a study on physical therapy with versus without photobiomodulation for patients with low back pain with depression. So again, it's a non-randomized study. It's a similar group that was used as a control group, 5 patients in each group, so a small study. And they compared a group that only received the physical therapy and another group of physical therapy with photobiomodulation. In this 12 points you can see here in the figure. And they had, again, preliminary but very interesting results. This is the scale they use it to assess improvement, and this scale has an item on depression symptoms. And they found a significant decrease in depression severity in the patients who received the combined treatment, photobiomodulation plus physical therapy. And a similar outcome was observed in the functioning, and this is a scale for functioning.
Marco, I was at the NALT meeting when these results were presented, and everybody was scratching their head, because this is one of the first times that I think it was kind of hit the mainstream of the indirect effect. You know? And I use this one to talk a lot about the indirect effect of, like, you know, we know that people in pain are depressed.
Yes.
But you know, how can you treat the body? And this was like the first time that I really was aware that you could have an indirect effect with the light therapy or photobiomodulation. So thank you for including it.
Yeah, thank you. Yeah, I heard from a Brazilian researcher, I think these results are not published yet, where they've made a trial inducing inflammation in a rat feet, and both feet of the rat.
Feet.
And they treated only one of the feet with the light, and the inflammation decreased in both feet. So it seems to have a systemic effect of the treatment, right? Yeah. So summary of this review is that, first, we know that we need new treatments for depressive disorder because of treatment-resistant depression. We have an opportunity to explore the mitochondrial mechanisms for treating depression that's not explored yet. And photobiomodulation fits these needs. And also it's a relatively inexpensive treatment, so it can be used widely. It's usually well tolerated. It's simple to deliver. There are a lot of devices in the market that people can use at home. But we don't know how much effective it is yet. And with kind of patients will benefit more. It probably may be effective for some patients and not for others. So we need more studies on that. And also we don't know the ideal parameters of stimulation for treating depression. And those are very interesting research points to have now. My current perspective, so I'm collaborating with a study in an animal model where we are going to assess behavior results of the treatment, and also a proteomic assessment of the brain tissue of the rats. This study is ready to start. We're just waiting the COVID-19 situation to stop, and it will start.
The rats don't get COVID-19. Well, you know, we can still take care of rats. Everybody else has got to wait. You know? I mean, I got backache. Well, what? No, you have to stay home. Well.
Oh yeah, that's complicated. Yeah. And as I told you, I submitted this grant for a randomized controlled trial on treatment-resistant depression. I'm calling it a translational randomized clinical trial because we are going to assess symptoms, but also mitochondrial biomarkers and oxidative stress biomarkers. So we hope to better understand the effects of photobiomodulation and maybe to predict who will benefit most of the treatment. And to finish my presentation,
Precision medicine.
what I see in the future of photobiomodulation for major depressive disorder. I think we are worried about precision medicine and to know which treatment to deliver to each patient. And I think photobiomodulation fits very well with this principle. I hope that using fMRI or fNIRS, we will be able to assess which parts of the brain are most inactive and stimulate these parts of the brain, and also to select the patients which will benefit more based on serum blood biomarkers of mitochondrial activity, so we can make the right treatment reach the right patient.
Excellent. And you know, just to touch on this for 1 second, this is a very elegant interpretation here, because let's just say this. Let's just say you used the NIRS, or the near infrared spectrography, to look at oxygen utilization. You know, one of the things that you can do is have that be, you know, let's say we give you a stimulation. Let's say you know, this is what you've written, but even if you did a thermographic picture, you could see how much change did I get in oxygen with this patient.
Yes.
How much change in temperature did I get with this patient? That means that that person has the quote unquote ability to process X to give you Y, right? So you can kind of give a half a dose parameter. And then to look at the patients based on a mitochondrial biomarker is also beautiful, because, you know, if they have mitochondrial dysfunction, and you give them the light, well, it's not going to turn on as much as if they have a healthy mitochondria. It's going to probably hit the ceiling, whereas the other one might not get off of the floor, correct?
Correct.
So I think that's a very, very elegant perspective. Go ahead.
Yeah, and just to finish, I think that the future of phytobiomodulation is probably involve more invasive treatments, you know, like I know that some groups are testing, at least in animal models, implants of light sources into the brain, very similar to deep brain stimulation, and considering penetration issues and this, I think we'll probably achieve more invasive treatments, implanting or just through the blood system, like they do catheterisms. They could reach the brain with the catheter, but the light source close to the stimulation aim.
Well, Dr. Ivan is going to be on, the one that did the intracerebral catheter. He's going to come on from Russia and show us his results, which I've looked at the slides. It's pretty amazing. If you had a vascular injury, you know, and that guy was around, you know, I want him to do it to me by looking at his results. But the question I have for you, so I want to thank you. I'm going to pop off a couple of questions now.
Okay.
But you know, here you touched about the invasive protocols. Now, being a psychiatrist, you're not going to be able to stick anything in anybody's brain at this point, you know. So wouldn't you, as a clinician, want to have a treatment that you yourself could utilize for your patients? You know what I'm trying to say?
Yeah, I see. No, I see. Probably transcranial photobiomodulation can be much more widely accessible, help a great number of patients, but I think there will the most treatment-resistant patients when we have like a precision model and we know, oh, that's the part of the brain that needs stimulation and transcranial is not working. For a small part of patients, I think will indicate more invasive protocols. Yeah.
And so I also like to talk about the side effects study. Because one of the things that Paolo noticed was one of the side effects was increased sexual desire, right? So, you know, that's a good side effect. You know, it's like losing weight and being sexier, you know? So we should point that out. But can you talk just for a second, if you could, based on your mastery, like, you know, sadness, you know, melancholy, depression. You know, I was reading a study yesterday that these talked about when people were nostalgic, they used to have a feeling of the times in the past were good times, or you're remembering good times. That used to be considered a disease. So they used to try to do all this stuff because people were nostalgic. Well, that's not normal, thinking about the past. So, I mean, when people are depressed, we're seeing that there's like, what do we see with a person's brain when they're depressed? Hypoactivity, too much activity. It's mostly hypo, right?
Mostly hypo, particularly in the dominant hemisphere. There are some studies showing that in the right hemisphere may be a little bit of high activity, but mostly low activity. Yeah.
Low activity. And, you know, with the rampantness, it's coming up a lot more. I mean, you see the future like a little bit more invasive to affect this. But a lot of people are saying, you know, that we could have devices that if you're feeling a little bit blue or if you're feeling a little bit down, you know, people right now, they're doing an app on their phone to, you know, not be as anxious or to kind of cheer them up a little bit. These are like the mild, early, maybe I just don't feel nice versus the major depression that are near suicide and things that you're talking about, right? These are the people that you deal with. People who just, they're very, very down, right? And so you think that some, you know, with the application, so few people in your clinic right now, what are you doing on these people? I mean, you using a laser on their head type thing or what?
For people who are very severe and treatment resistant, well, we are mostly doing standard things like we have a very effective treatment for this very severe patients, which is electroconvulsive therapy. Yeah, and still we are still using laser in experimental treatment and doing research. We're not yet delivering for clinical work. Yeah.
Right. So the thing that I look up is, you know, we can affect the brain. We can affect the brain's metabolism, and the work that you're doing is helping us become a little bit more precise, because we know that there's a lot of stimulatory things out there like electroconvulsive and big magnets and everything like that. You find that they're always going to be around, you think, because it's more traditional until more studies come out of what the different light energies can do?
Yeah, as I told you, I believe that depression are a group of different disorders. So what I hope is that in the future we'll know which kind of the stimulations will work. We'll be able to predict which kind of this different stimulations will work better for each patient. And considering our theory, those with more mitochondrial dysfunction will benefit more from light therapy, right?
I think that you're on the right track. I'm glad that I have my brothers down there in Brazil working on something like this with the dedication that you're putting in. Thank you so much.
Thank you so much for inviting me, Joy.